The selective dorsal rhizotomy is a neurosurgical procedure for children who have difficulty walking. It's typically for young children, perhaps 3 years to 12 years old, that have difficulty with walking with their legs. They typically have increased muscle tone in their legs, and that's referred to as spastic diplegia. They typically have the potential to ambulate on their own. So they may be walking with a walker or walking with canes or just with braces. And the idea is to help them ambulate better and for them to have better outcomes overall. So the best candidates are young children who have spastic diplegia that are motivated and capable of working with their therapist. So those are typically kids that are 2.5 or 3 years old that are able to get through significant therapy regimens, maybe a few hours a week at least. It's ideal if the kids can realize that they're doing the therapy and working on walking better for themselves. So they need to do the therapy program because they want to walk better, not just because it's what mom or dad asked them to do. It's also helpful if they don't have many other medical problems and they're going to be able to cooperate with the intensive therapy regimen afterwards. Typically we perform the surgery and then the children need to receive very intensive physical therapy for several weeks and often at least a few months afterwards. We need to do both the surgery and the therapy afterwards to retrain the brain. So the surgery itself involves a procedure under the microscope in the operating room. The children are completely asleep throughout the entire procedure, and it usually takes about 3 to 4 hours. Under the microscope, we make an incision in the spine and expose the nerve roots at the very bottom of the spinal cord after they've come off the spinal cord. We select out the ones that are the dorsal sensory roots that control the feedback loop from the muscles back into the spinal cord. And under the microscope, we test those roots and divide them into little rootlets and test those rootlets to find the most abnormal ones, and then we cut a certain percentage of the most abnormal ones. We then close everything up, and the children are usually in the hospital for at least a few days. The best time to have the procedure is when a young child is old enough to realize that they're perhaps walking differently than their siblings or their peers, and they're motivated to learn to walk better. Most of these children are very involved in a therapy program already, and the ideal time is to capture them after they realize that if they work hard in therapy, they can walk better and do better. But before they get to be old enough, say in grade school or middle school, where they realize that they're perhaps different, and that starts to have negative consequences. So we now have some excellent long-term studies from around the world that demonstrate that children can have excellent long-term results 10 or even 20 years out from selective dorsal rhizotomy. And that's our goal, is for these kids that are having difficulty walking, say before they're entering kindergarten, to have them in the best place possible as they head off to college. So our goal is to sort of reset the meter that controls the tone in their legs and help them walk better. We like to do it before they become teenagers typically, and sort of all of us have less plasticity in our brain when we're older. We're very fortunate here at Johns Hopkins that we have an excellent team approach to taking care of these children. So we work closely with our colleagues in anesthesia and pain management to help reduce the difficulties around the perioperative period, and then we work with our colleagues in neurology and rehab and orthopedics to design the best individualized program for each child.